Hi everyone, good afternoon. Thank you so much for being here with me for another I Care for Your Brain live free brain health lecture. Our two goals are education and empowerment, and I want you to have the best high quality information about your brain health as possible because you deserve it. We are going to talk today about the four most common questions that I get as a board-certified neuropsychologist as they relate to dementia. Dementia is a topic that is near and dear to my heart. It's the whole reason that I am sitting in front of you today. Some of you know I was a caregiver and worked in many different types of facilities before I went to graduate school and became a doctor. I very much appreciate those years because I feel that it really helps me to be a better provider, because not only did I learn about this stuff through excellent mentors and books and clinical experiences, but also to know people, to have loved people who have lived through dementia really informs the type of provider that I try to be and the type of support that I try to provide my patients with. So what I wanted to do today was to go over these four questions because they really do come up over and over again. And I think that means that they are very ubiquitous and that a lot of you out there may be wondering the same exact things. So let's just start off with the most straightforward of questions. What is dementia? Dementia is an umbrella term that simply means that there has been a significant decline in one or more cognitive areas. So this can be memory, this can be language, this can be attention, this can be visuospatial abilities, but there has to be two other components to meet the criteria for dementia. The first one is that there is always mood and behavior changes as well. And the effect, the impact of these cognitive and mood changes has to be strong enough to interfere with what we call instrumental activities of daily living. And this is critical to know because so many people want to know, when should I really get worried? I've been observing some things. I'm concerned about myself. The line in the sand really is, how are you doing in everyday life? And we look at these three specific areas that we call instrumental activities of daily living. This is driving, remembering how to get to and from places safely. Number two is remembering how to take your medications independently and really being able to keep up with the system to do that every single day like you're supposed to. Number three is being able to manage money. And in fact, money, it turns out, is probably the most complex of those three. So things like being able to balance a checkbook, being able to really be on top of your bills. Remember, this bill goes with this company. How am I getting the amount that's on the bill onto the check, into the envelope? There's a lot of steps that actually go into complex financial management. So if someone is able to do all that well and independently, it really can't be dementia. So one of the big questions that comes up is dementia a part of normal aging? And it's absolutely not. That is a stereotype. We have all these terms that have been used for so long: old-timers disease, right? Senility, just this idea that if you got old enough, inevitably you would develop dementia. And that's absolutely not true. There are so many people that are in their 90s and in their hundreds that are clear as a bell. You guys all know these people, right? And there's actually some research to say that if you get to be about the age of 90, 91, 92, and you still don't have dementia, you're pretty much going to be okay and dementia-free for the rest of your life. It's really interesting. So as I was saying, dementia, you can kind of think of it like an umbrella term. It's just very broad. That means that there has been a change for this person in one or more cognitive areas, and it has to affect mood and behavior, and it has to affect everyday life. Dementia is caused by many different types of brain diseases, but they all have one common outcome, which is that they damage brain cells. And what happens is the brain cells either die or their ability to communicate with each other significantly diminishes. So most dementias start off in very specific parts of the brain, and over time they spread to the whole rest of the brain. And this is of course why you see progression of symptoms from mild to moderate to severe, because over time more of the brain is getting to be involved. We have about 50 different types of dementia that we diagnose, and all of them are progressive, unfortunately. The most common ones are Alzheimer's disease, Lewy body dementia, which you might not have heard about and will actually be my topic next week. I'll tell you more on that at the end. And something called vascular dementia, which is after you've had one significant stroke or maybe a few smaller strokes, you can meet criteria for vascular dementia because you've got these focal injuries all around the brain and it's very hard for the brain cells to communicate. We definitely want people to understand that the symptoms of dementia are not just memory problems, okay? That may be the case for typically presenting Alzheimer's disease, but we have a lot of dementias, frontotemporal dementia, for example, where personality change, behavior change, these are the most significant factors. We have Parkinson's disease dementia, in which a motor symptom, a motor disorder, is the most significant type of symptom. So it really depends. So one of the take-home messages for me today is if you or somebody that you know is ever told, well, we think it's dementia, you will now be empowered to say, okay, that's a good start, but I want to know what type of dementia it is that I have, okay? And that matters when we get to, I think it's my fourth question about treatment. What do we do about dementia? The type of dementia dictates the treatment. So if someone just says dementia, we're a little bit in the dark, okay? So we need to get much more specific. So like I was saying before, we know that dementia is this umbrella term, and underneath that we have all these different types of dementia. So a big question that I get, my second one, is what is the difference between dementia and Alzheimer's disease? And it's a great question. So Alzheimer's disease is a type of dementia, okay? So you can have dementia but not have Alzheimer's disease. But you cannot have Alzheimer's disease and not have dementia. Does that make sense? Okay, so interestingly with Alzheimer's disease, scientists don't 100% really know the physiological changes that happen that result in the symptoms. But we do have some pretty good ideas. And of course, billions of dollars are being spent on this, every single year. So there are these things called plaques and tangles in the brain, and we think that this is really what happens within the brain cells and right outside them that basically kind of puts a stranglehold on them and keeps them from getting the oxygen and the nutrients that they need. And this leads to cell death, which of course leads to brain matter going away, dying. So plaques are abnormal clusters of kind of like sticky little proteins called beta amyloid, and this builds up between the brain cells or the neurons. They can do a couple different things. One thing we think is that they can really trigger an inflammatory response in the brain, which is not good. And all of the changes that happen in an inflamed brain can cause more damage, more disability to the actual brain cells. There's also something called tau, which in a healthy brain has really important functions. But basically this is what builds up actually within the cells. So we've got the plaques outside, we've got the tau inside, and in a normal healthy brain, we are all making little bits of plaques and tangles all the time, but we have this cleaving and this clearing out process that comes along kind of like a little garbage truck, and the plaques and tangles get thrown in the garbage truck and it goes to the dump and it gets rid of it, it gets excreted throughout the body. Well, really what happens in Alzheimer's disease is that this clearing out process breaks and it doesn't work, and you get a buildup of these things in the brain, and this is where we have the problem. So in Alzheimer's disease, we have two different types. We have early onset and we have late onset, and the differentiation there is age. So if you are 65 or younger before you develop Alzheimer's disease, this is considered early onset, and we think about 5% of all the people in the world who have Alzheimer's have early onset. The other folks are what we consider to be late onset, or some people call it insidious onset. there is a big genetic difference between these two. So early onset Alzheimer's is pretty darn genetic, meaning no matter what these people would have done throughout their lives, they were probably going to develop early onset Alzheimer's, which of course is very frustrating because a lot of us put a lot of time and effort and heart into doing things that are going to keep us well as we get older. And sometimes the genetic power, the genetic instructions in our cells are just too strong that no matter what we do environmentally, that disease was still going to manifest and express itself. So for folks with early onset, there's typically a known family history. And those are the folks where we do think about things like genetic testing for family members, because for some people it's a very ethical, personal decision, but for some people they would want to know. Late onset Alzheimer's after the age of 65 is thought to have a genetic component, but that there was something in the environment that turned on those genes. And that is the $65 million question. If we knew what it was that turned on those genes, boy, would we be doing everything possible. We have some really, really good ideas that are supported by research, which is a huge part of this I Care for Your Brain program, is how can we bring that solid research insight and expertise to you as the general public to know what exactly to do. That's the essence of basically why I'm here, is how can I get that information in medical journals to you directly. And that would be a great topic for a whole lecture in the future. But basically the things that we know have the most influence are your cardiovascular health, specifically keeping your high blood pressure down, keeping yourself from developing type 2 diabetes, and if you do have it, from keeping your sugars from spiking either way low or way high. Things like cardiovascular exercise, the MIND diet has been shown to reduce instances of Alzheimer's disease. So we have things that we know that we can do. Within Alzheimer's, we also have typical Alzheimer's and we have atypical Alzheimer's. So typical Alzheimer's, as you might expect, has a much more typical progression, and it typically starts in a part of the brain right about here called the medial temporal lobes. And what this part of the brain does is it helps us learn new information, basically take experiences that are in front of us and package them into little memories. And there's kind of a transfer process that happens there from immediate memory into short-term memory. And that's why the very first signs of Alzheimer's cognitively are involved with memory. Now, of course, over time it spreads. The next area that it tends to go to is language. So people who have Alzheimer's can have trouble finding their words. Sometimes they can have trouble with articulation. And eventually it unfortunately spreads into the whole brain, even including things like basic functions like breathing and swallowing. Atypical Alzheimer's is people that we strongly suspect have Alzheimer's in their brain, but memory is actually not their first symptom. So there is something called posterior cortical atrophy, in which it is an Alzheimer's pathology in the brain, but it's happening more in the back part of the brain called the occipital lobe. And what you get is a lot of vision symptoms. So it's almost as if people are going blind, not at the level of the eye, but at the level of the brain. And typically these people have really well-preserved insight and awareness into what's happening to them, which makes it particularly painful. One of the first symptoms of Alzheimer's disease, though, and I think this is worth spending a minute or two on, is not memory. So for many people looking back, they will tell me the first thing was actually personality change. And when something is as slow and as gradual in its onset as Alzheimer's disease, it's really only looking back that you have that, expertise of knowing what you know now, to know, oh, okay, I think there was something going on there, where it's very easy to explain things away in the moment, to think it was due to stress, or to think someone has maybe a medical issue that was going on. But looking back, people typically tell me, I think it was a lack of interest in things that the person used to enjoy that was really the first change. And that makes sense with the chemical changes that we know happen in Alzheimer's disease, which can really involve things like our motivation and our initiative to be interested in things. So it's important to keep in mind, though, that that same symptom can also happen in things like depression. It can happen in vascular disease from not getting enough blood flow to the brain. And this is, again, why a neuropsychologist can be such a great care partner for you, because our job job, our expertise is in sorting all this out so you really have a good understanding of those layers that are contributing to the brain change. So my next question is, how does dementia get diagnosed? Well, the gold standard for diagnosing dementia is from a neuropsychologist. We are able to accurately diagnose dementia in about 90% of people, according to the research. And neuropsychological assessment, which I'll explain to you in a moment, has been shown to be more effective than brain imaging, so MRI pictures of the brain, for detecting the progression of memory symptoms in people with Alzheimer's disease and something called mild cognitive impairment. And this is really based on a very important principle that we've talked about before, which is the difference between structure and function in the brain. I have seen beautiful MRI pictures. This brain looks so healthy and happy, and when you test the person, the functioning, the ability of the brain to do things is very, very impaired. I've also seen, and this is more common, I've seen brains that look really bad, really, really diseased, a lot of atrophy, a lot of shrinking, big areas of damage from strokes. And in life, the person can compensate. They have enough what we call cognitive reserve to be able to find other ways of going about getting to the same endpoint. So the picture of the brain, to me, often gets propped up a little bit too much. Very important for research, very important for diagnosing specific things, brain tumors, strokes, fractures, hydrocephalus, all water in the brain, all sorts of different things. But in terms of dementia and progression of dementia, there is nothing like neuropsychological evaluation. So let me tell you how it is we do this. So we basically use 3 tools to come up with our diagnosis and our comments on progression. The first one is you have to have time to go through the person's medical records with a fine-tooth comb and really appreciate all the medical history, the medications that the person takes, and how exactly is it that their whole history of their physical health comes together to the person that you have in front of you in the interview. The interviews that we do is the second part, and this typically is over an hour. When is the last time you had a doctor take an intake on you that was over an hour? We go from soup to nuts. We're talking your mother's pregnancy of you all the way up to your ability to follow a recipe today. We want to know it all. We really are information gatherers, and we are a very curious type of doctor, and we really have kind of a detective approach because there is logic and a pattern in what it is you're going through. It's just someone has to be able to do that level of analysis to appreciate complexity and appreciate multiple things that could be coming together. One of the things that I think is not so great about our medical system now, which is probably also its strength to some degree, is we have a lot of hyper specialists, people that only deal with very, very, very specific problems. But one thing we've lost are good, high quality generalists, people that can really appreciate what's going on in the mind and what's going on in the body. And that is essentially why I chose neuropsychology, is because we really do respect the physicalness, the neuro part, the brain part, but we also really care about the person, the psychology, the social being, the adaptation, the family effect. There's all these different things. So our job in the interview is to mine through all those domains and figure out, okay, that matters, this might be a factor, and we're just starting to kind of figure out the map. We then use paper and pencil testing, which typically takes about 2 to 4 hours per person, to basically take a tour around the brain with paper and pencil test to figure out how is this person's brain doing compared to how they would have done in their prime. And we actually have tests where we can ask people to do things now, and they do it almost the same exact way they would have done 20, 30, 40 years ago, and that kind of gives us our baseline. And then we have tests that we know reflect how the person is now. So we can compare how the person is now to their own baseline, which is very cool. And we can compare how that person is doing now to their peer group. So this is other people the same age as that person and the same years of education, sometimes the same handedness. Very, very interesting. So what we are doing ultimately is bringing all of these different factors together and figuring out, is this the pattern of normal aging? Is this the pattern of dementia? If it is dementia, what kind of dementia? Now here's the thing. It may be more than one kind. There's something called mixed dementia. It's not necessarily just revealing, aha, this is the one big thing. I tell you guys this all the time. What I have found to be true is layers, 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 layers. Yes, there may be vascular dementia, but there also could be the effect of uncontrolled diabetes that's happening every day. Lack of exercise. Person could have been a military veteran and never got treatment for post-traumatic stress disorder. They could not be eating good enough every day and would benefit from Meals on Wheels. I mean, there's many, 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 many things that we go through. So we need to do this level of analysis because the brain is very complex. People are very complex. And this is why I go berserk talking about screening measures for dementia, because it's simply not enough. How could you possibly, in a 30-item screening measure that takes 5 minutes, come to any real conclusion about the brain? And I bring it up a lot because I know a lot of you out there, that is the extent of the evaluations that you're getting. And the only way you're going to get something better, something more adequate, is for you to advocate for your doctor that you want a more comprehensive evaluation, to see a neuropsychologist. Is there a cure for dementia is my next question. Well, treatment for dementia, of course, depends on the cause. I wish that there was a cure for all the dementias, but there is not. There are something that we call treatable dementias that are due to things that once you treat the issue, like a vitamin B12 deficiency or an alcohol issue, you can actually get the person much better. In my experience, these are more rare than I wish they were. Most dementias, unfortunately, are progressive, and the medications that we have on the market now, what they do is they actually slow the symptoms down for a longer period of time than would happen if you did not take the medications. Interestingly enough, we don't actually think that these medications, I'm going to tell you what they are in a minute, affect the disease progression in the brain. What they actually do is they slow down the expression of the disease. Does that make sense? Kind of amazing. But the thing is about these medications is that you want to have the person take them as early as possible, because that's when you're going to be slowing down the symptoms. So let's just say the progression of Alzheimer's, it's kind of goes like this, kind of gradual. The idea is that the medications are, you're still going to go down, but maybe the slope of that decline will not be as steep for a longer period of time than it would be otherwise. We have medications that we consider for mild stages of dementia, and then other ones that we add in when it progresses to more moderate or severe. At the present time, we have 5 FDA medications for Alzheimer's disease. Some other types of dementia are included there, but they really work through 2 different types of communication changes that they set up in the brain. So the first one is called cholinesterase inhibitors, and these work by slowing down the breakdown of an enzyme in the brain called choline. And the first one came out in 1996. This is donepezil or Aricept. Another one came out in 2000 called Exelon, and in 2001 we had galantamine. So all of these are kind of in one category. And then we have another category which only includes one medication, which is Namenda or memantine. And this came out in 2003, and this works on a different mechanism, which is basically regulating the activity of a neurotransmitter called glutamate. Glutamate is intimately involved with calcium, and the idea is if the channels in the brain cells are too open for these chemicals, that it can be kind of damaging and caustic to the brain cells. So what these do is basically try to limit the exposure of glutamate and calcium into the brain. We do have a new medication that came out in 2014 called Namzaric, which a lot of people got excited about, but unfortunately there's nothing new about it. All it is a combination of 2 old medications together, Aricept and Namenda, or donepezil and memantine. And the idea is that the gold standard used to be Aricept in the mild stages, and once you got to the moderate, you stopped the Aricept and you went on to the Namenda. Well, now the gold standard is actually, once you get to the moderate stage, you're actually going to keep your Aricept or donepezil and add in the Namenda or the memantine. So basically, the Namzaric is just having you take one pill instead of two. So the effectiveness of these medications vary a lot across people, and they really are just related to cognition. Now remember what I said is in dementia, we also have behavior symptoms. So one thing that I am really enthusiastic about is to try to help with the way people approach medication changes in dementia to include mood and behavior changes. And part of that is outside my realm of expertise as a neuropsychologist, and so that we leave that more to physicians and psychiatrists, but I can kind of comment on it and have some thoughts about it. So because so many people do experience things like a lack of initiative, a lack of motivation, anxiety, agitation, a lot of patients that I see, I work with their physical medicine providers to think creatively about maybe mood medications and to treat the person. And that feels like a more complete medication approach than just treating cognition. Now, of course, we don't want to over-medicate people, and we don't want to just turn to a pill for every single thing. So we work a lot as neuropsychologists with families and individuals to do what we call behavioral strategies or behavioral interventions, because if someone is having a hard time with communication, many times behavior becomes a form of communicating. Or if we're not respecting the psychological experience of dementia, and that it may be, of course, very difficult for the person to be losing a sense of control and that sense of stability and continuity that memories provide us with, of course, some people may get agitated and kind of act out. So we, as the people who love them and care about them and are surrounding them, really need to figure out what we can do to support them before we go to medication. That being said, though, I've worked with enough people where medication was the only thing that we could bring on that would reduce the person's stress and improve their quality of life. So when we are done with the neuropsychological evaluation, the whole point is not only diagnostic clarity, so what exactly is this, but what we really care about, and I think this is really what you guys want, but maybe haven't known the right doctor to go to, is a comprehensive care plan. What can we do to actually help this person that we care about so much who is having these problems? So we do things like connect people with community resources. We try to help with home strategies to improve independence. Remember that layered approach of problems in the brain? There's always something else that we could be doing to reduce the severity of the dementia. That happens all the time, and that's very rewarding from my perspective, because many times people come to see me and they think there's nothing that can be done, that once you get a diagnosis of dementia, that's kind of it. But that's absolutely not the case. So you should absolutely be seeking out a board certified or a board eligible neuropsychologist, and you can do this by going on Google and just writing in find board certified neuropsychologist. You can click a little tab that says clinical neuropsychology. You can put in your state. You can even put in your zip code and pick how far you want the radius to be, and they will give you the name and contact number for a provider in your area. If you do not have luck with that, you message me here on Facebook and you tell me where you live, and I will do my best to find someone local to you. I am in North Carolina, and so the people that see me have to be here in my office. Telehealth has not developed to the point where we can do neuropsychological evaluation outside of our state. So people get in touch with me often to ask if I would be able to see them, and of course I would be more than happy to, but there are limitations and legal issues that keep me from being able to practice more widely. That is everything that I wanted to say to you today. Next time we're going to talk about Lewy body dementia, which is, some argue, the most common form of dementia. I would say it's right up there with Alzheimer's disease, but it's certainly the most poorly understood form of dementia, and we really need to talk about the symptoms because they get misinterpreted so often. So I will be back with you again next week. Thank you guys so much for listening. I hope this was helpful. As always, I love when you write me comments and let me know that you appreciated what we talked about today and that it was helpful. And liking it and sharing it is great. It's a perfect way to help spread our message about brain health, education, and empowerment. I will see you guys next week. Have a great day. Bye-bye.